Hello and welcome to World Parkinson's Program question and answer session. You can join us live on Facebook as well as YouTube. Please let us know where are you joining us from, and also please forward this link to your friends and people you know so that they can ask us questions. We try to make these sessions interactive. These are not lectures. These are only for sharing experiences and discussion, and also these are for educational purposes only, so that people can benefit from each other's experience. So kindly send this link to others and inform your friends and families to join us. So thank you. And these sessions for now are taking place on Saturdays, every Saturday at 3 p.m. Eastern Standard Time. Welcome to Toronto. So we will be taking your questions and trying to answer to the best of our capability. And for details, you can also visit our website www.pdprogram.org, World Parkinson's Program. World Parkinson's Program is a Canadian-based global charitable organization which is much different than other Parkinson's organizations which are focused on research. So World Parkinson's Program is focused mainly on addressing the day-to-day needs of every Parkinson's patient. Every Parkinson's patient needs medications. Parkinson's patients do need walking aids in late stages as well as educational literature throughout the course of Parkinson's disease on their changing condition. They need to know what is coming next, what to expect, and how to deal with these conditions. And World Parkinson's Program provides educational literature in more than 20 languages on various aspects of Parkinson's disease, and also tries to reach those who are not able to afford medications for Parkinson's disease, as well as who are not able to afford walking aids for Parkinson's disease. So please contact World Parkinson's Program if you are a neurologist or a physician or a patient. You can contact through your physicians asking for request for providing medications for Parkinson's disease free of charge. So thank you for joining us. We will be taking your questions and answering them. So please stay tuned. Thank you again. The website again is www.pdprogram.org. So first question is, I am not responding to L-DOPA. Is it a automatically MSA? So with respect to lack of response to levodopa, there are many possibilities. Patients who have idiopathic Parkinson's disease and in early to moderate stages, they most often or almost always respond to levodopa. Some physicians feel reassured when a patient responds to levodopa that the diagnosis is idiopathic Parkinson's disease. However, in conditions such as atypical Parkinsonism, such as multiple system atrophy or progressive supranuclear palsy or corticobasal degeneration, the response to levodopa is partial or much less, and sometimes patients may not feel much of a response when they take levodopa, especially at the lower doses. So in cases of idiopathic Parkinson's disease, as the disease progresses, when patients reach stage 3 or beyond, the response to levodopa becomes very much less noticeable, and some patients may say to us that they don't notice anything even if we have increased their medications. So that's idiopathic Parkinson's disease. So as I said, to recap, in early to mild stages or even in moderate stages of idiopathic Parkinson's disease, patients usually or almost always respond to levodopa, which is very reassuring. Whereas in late stages of Parkinson's disease, the response to levodopa becomes partial, and some patients may have dose failure or lack of response. That does not exclude the diagnosis of Parkinson's disease. Whereas in cases of atypical Parkinsonism, such as multiple system atrophy, especially because you are asking question about multiple system atrophy, patients may respond but only partially, not as robust as in cases of idiopathic Parkinson's disease. However, just based on this fact that a person is not responding to levodopa, it's automatically MSA. It is not, because for MSA, usually patients have many other symptoms, such as they have bladder dysfunction, they have lightheadedness or dizziness due to autonomic dysfunction, they may have diarrhea alternating with constipation, and also sexual dysfunction. So these patients have these symptoms, and there is usually a lack of asymmetry. It means that the symptoms of patients are present on both sides of body, and these symptoms are almost symmetrical, whereas in cases of idiopathic Parkinson's disease, the patients have asymmetrical onset of the disease, and usually in early to mild stages this asymmetry is remained, whereas when the idiopathic Parkinson's disease become advanced, then patient may lose asymmetry and symptoms may become equally prominent on both sides. So it's not automatically MSA. We sometimes need to go back to the patients and look for some of the signs and symptoms which may not be prominent in earlier on, and this is not uncommon to be confused about the diagnosis of idiopathic Parkinson's disease and MSA, especially when patients don't have a tremor. But as the course of disease progresses, patients may notice more of symptoms evolving, and the diagnosis may become clear. However, in cases of experienced physicians who specialize in movement disorders, usually diagnosing multiple system atrophy in the beginning, of course, is not very difficult. John Bauman is online, and he's saying, once one is diagnosed, can you explain the phases or stages? How are they defined? John, thank you very much. John hopefully will be taking some live Facebook sessions. I think he will be on towards end of May or probably June. So I will take a break and give these sessions to John. I think he is getting ready. Back to John's question. Yes, once one is diagnosed, can you explain the phases or stages? The stages of Parkinson's disease are of many different types. The most commonly used staging system is Hohen and Yahar staging. The Hohen and Yahar staging is based on the clinical symptoms of patients, and there are 5 stages. The first stage is when the disease is only on one side. If patients have only one side of body involved, then it's Hohen and Yahar stage 1. Most patients in Hohen and Yahar stage 1 may not be presenting to physicians. So if they have both sides of body involved, then it's stage 2. So usually one side is more involved than the other, but both sides are involved. So that's Hohen and Yahar stage 2. And then if patients have balance problems, then it's Hohen and Yahar stage 3. And then if patients are not able to carry on their daily activities completely, although they are semi-independent, they are not completely independent. So in between, that stage 4. And if patients are bed-bound or wheelchair-bound and they are completely dependent upon others, that's stage 5. So having said these 5 stages of Hohen and Yahar system, so there is a little bit modification of these stages. So modified Hohen and Yahar stage includes stage 1.5 and 2.5. With stage 1.5, the symptoms are involving one side of body, and there is some axial or midline symptoms such as stiffness or rigidity. And in 2.5, patients have some balance problems, but not to the extent that they are falling, obviously. So mild balance problems with two-sided staging, two-sided disease is stage 2.5. So again, to recap, in Hohen and Yahr stage, the classical system is stage 1, 2. 1 is one side of disease, one side of body is involved. Stage 2, both sides. Stage 3 with balance problem. Stage 4, they are not completely dependent, but they do need help of others. And stage 5 is completely dependent. Modified Hohen and Yahr stage is stage 1, one side of body is involved. Stage 1.5, one side of body is involved with some midline rigidity or other symptoms. And stage 2 again is both side of disease. Stage 2.5 is both side of disease with some balance issues. And stage 3 is significant balance issues with two-sided disease. And then stage 4 and stage 5 are like the regular Hohen and Yahr staging system. So there are other systems such as Schwab and England scale, which ranges from 10% to 100%. That's usually not used. It's extensive. It may be used in some parts in the research studies, and there is another system, UPDRS rating scale, that's also mostly used in research studies, but we do use in clinical settings, maybe partly, such as stage UPDRS2, activities of daily living, or UPDRS3, the motor subset. We use for scoring. And then there is another one, modified UPDRS, Movement Disorder Society UPDRS system, which may be taking over in future. So another question we have is, I would like to ask, why is that my medication take complete effect and other times it does not? So yes, with respect to, I believe you are talking about levodopa. If it is levodopa, so as I always say, Parkinson's is a fluctuating condition. So sometimes patients take medication and they start feeling on within 10 to 15 minutes. The effect of the medication starts right away, and patients can move around, they can do their daily activities. But at other time, it may not take a complete effect right away. It may take some time to start working. It may take half an hour, 45 minutes to an hour, and at other time it may not take the effect at all sometime till the next dose. That's called dose failure. So the first thing, when it takes effect right away, that's the on feeling. That usually happens within 15-20 minutes, sometime up to half an hour. And delayed on is, if it is delayed than this, then we call it delayed on, and sometimes dose failure can be problem, and levodopa does not take effect. There are many different factors to this. Now, for example, if the medication is taken with food, then the absorption may be delayed. If there is some protein part in the food, then absorption may be further delayed. And sometimes, if the medication is taken on an empty stomach, it may absorb right away. So food and many other factors affect this. Sometimes we tell patients to take levodopa with carbonated drinks or with orange juice. That somehow helps these medication to absorb quickly. So yes, it's true that sometimes it affects, sometimes it does not. And some patients do feel that if they are active physically when they take medication, they start feeling on quickly. And if they are not active, then the on may be delayed. These are various experiences which patients have shared with us. It's a fluctuating condition, and also it depends on the medication. Sometimes if you use a control release form of levodopa, which is called CR, levodopa CR, that may not kick in right away because of poor absorption. And sometimes because of poor absorption, if you take a CR, it may not kick in, and then you may take another dose after some time, and due to unpredictable absorption, both doses may kick in, and patients may go into dyskinesias. So it depends on food and many other factors, and physical activity, and how you take medications, if you take with water or carbonated drinks, and also what formulation of medication you take. I believe the capsulated form of levodopa benzoyl may kick in a little bit delayed than the levodopa carbidopa, which is the tablet form. Another comment we have, my experience, John Bauman is saying, my experience is in limiting protein really help? Yes, limiting protein intake with levodopa does help, because what happens, protein, when we eat protein, they are broken down into amino acids, and amino acids compete levodopa across the wall of GI to get absorbed into the bloodstream, and when there are a lot of amino acids, they're competing with levodopa. So if you limit the protein intake, it does help with the absorption of levodopa. Sorry for my. Sometimes I have to look at the. I have three screens to look at, so there may be some interruption when I'm speaking. So another question is how is face involved in Parkinson's? That's a very broad question. Involvement of face in Parkinson's disease. So I often say that Parkinson's is a social disease. Parkinson's does affect our face involvement and other parts, other aspects of our daily life, which affect our social interaction with other people. The most common facial involvement in Parkinson's disease is lack of facial expression. Some people call it mask faces, stone faces, or expressionless face or flat face. In medical terms, sometimes it's referred as hypomimia. So what happens in these patients, their face become expressionless. A normal person, a healthy person, when they're speaking, you can see changing expressions on their face. So you can tell, for example, if a person is reading a letter and the letter has some good news, a person wins lottery or something, you can tell from their facial expression that the person reading a letter, something good has happened. Or if he gets a letter with some bad news, you can tell from the face that something in the letter is not good. So from the facial expression, you can tell the condition of the person. So similarly, with Parkinson's disease, the patients may not feel themselves that their facial expression have changed, but usually it's noticed by friends and family that their face has become flat, expressionless. They're sitting there, they have decreased blinking, they are just quiet, and their face appears like a blank staring face. So that's the most common manifestation in idiopathic Parkinson's disease. In other conditions, atypical Parkinsonism, such as progressive supranuclear palsy, patients have fixed facial expression. Their nasolabial folds may be more prominent. Their frontal folds may be more prominent. So these patients have fixed, more prominent facial expression, which could help to differentiate this from idiopathic Parkinson's disease. Other than this, there are some manifestations of Parkinson's disease on the face, which we will speak on. Let's move on to next question. Have you heard of the supplement? I have trouble reading it. It's supplement ATREMORINE. Atremorin. Have you heard of supplement Atremorin? What do you think of it? They are saying it is very powerful. No, I don't have any experience with this supplement. There are so many things off the shelf in the market which people claim to have benefit. I don't have any experience in my patients. Neither any of my patients reported to me that they are using this, and I am not sure. You need to make research. What are the ingredients of this? And has it been tested in scientific experiments? And has it proven to show the safety of use and efficacy in Parkinson's disease before you use any supplement? That's what I tell most of my patients, because we need to be sure what we are taking in with Parkinson's disease, because there are certain patients who do use legumes. So we try to tell them to avoid these practices, because sometimes what happens, we don't know exactly what is the content of these supplements which are available over the counter, and sometimes there could be dopaminergic supplement in these. There could be dopaminergic content in these supplements which may be unregulated, and it may lead towards dyskinesias and motor fluctuations. So we don't recommend using any of the supplements which have not been tested scientifically So let's go back to involvement of face in Parkinson disease. There could be involvement. We have another question, so let's take that question and then we'll go back to the face involvement. There is a question. Assalamu alaikum. My mother is taking half Cinnamate tablet after every 4 hours. Can this duration be enlarged, or can she skip the medication of that come during night? So levocarb, usually when it started, levodopa, levocarb, or Cinnamate or Prolopa. So there are various formulations and trade names. So when levocarb is started, we usually start it at 3 times a day, and that's only during the daytime. At nighttime, when patients are sleeping, we don't give them levodopa in the beginning. So as the disease progresses, the need for levodopa increases, then we may move on to 4 times a day, and sometime every 4 hours. So if you give 4 doses every 4 hours, that would be 16 hours a day. 16 hours in the day, patients can have availability of levodopa, and when they're sleeping, they might not need levodopa. So this comment is about half a Cinnamate tablet after 4 hours. Half a tablet of Cinnamate every 4 hours is quite a low dose. I don't think this is sufficient, although it depends on stage of your mother's disease. If she has very mild symptoms, and if she can manage with this dose, she can complete all daily activities, then it may be fine. However, the lowest starting dose is 300 milligram a day, and half a tablet 4 times a day would be, I believe, half a tablet will be 200 if she is using 100 or 25. So I am not sure what dose she is taking exactly, but the physician who is treating have to assess her mobility and daily activities, and then decide. It seems to me that this is a low type of dose. Yes, she can. The medication should be taken at a fixed time every day, and I tell patients to put an alarm on cell phone. There are devices these days only for medications which you can alarm 4 to 5 times a day, and they can remind you. Take a medication, even if you don't feel need for medication. When there's a time for medication, take the medication. What I tell my patients that you put a cell phone on cell phone alarm, and when the alarm rings, first you go and pick up the medication, then you turn off the alarm. That's I tell my patients, and that works very well, because if they turn off the cell phone alarm first, then there might be some other phone or some other things they might like to do, and then the medication may be delayed. So we don't tell patients to delay medication. She can skip medication at night time if she has no trouble turning in bed, if she has no pain or cramping, or no symptoms of Parkinson's disease. If she can sleep through the night time, then there may be not any need for the medication at night time. So let's move on to next question. So there are so many questions. I don't know which one is the fresh one. Sorry, I have a team of World Parkinson's Program helping me. Okay, let's take, yes, this is the lowest dose, lowest question. Sorry. Yes, here is my situation. Someone is asking, here is my situation. Rigidity in the right arm and leg since 3 years. My walking is difficult and writing is difficult. I don't have bladder or drop of pressure upon standing problem. No tremor. Put on 100 milligram levodopa with no response. Balance is okay. MRI shows stenosis. It is. I think he means to write is a PD. The cardinal most important and The most core symptom of Parkinson's disease is bradykinesia, or slowness of movement. You have not mentioned the slowness of movement. So it seems that you have rigidity on right arm and leg for 3 years. Walking is difficult, which is likely due to slowness. Writing is difficult, which may be due to slowness. You don't have bladder or drop in blood pressure upon standing, and there's no tremor. So it's likely based on very limited information and without seeing you in a clinical setting. Whatever information I can read from your email or message. So it seems that this is a non-tremor dominant Parkinson's disease, or sometimes we call it akinetic rigid Parkinson's disease. It does seem asymmetrical on right side of body, and you do seem to have bradykinesia. There is no tremor, so it could be that you have idiopathic Parkinson's disease without a tremor. It does not seem to be MSA just based on these 3 sentences. However, someone who is expert in movement disorders, they need to examine you completely, and after full assessment they can tell. You said 100 milligram of levodopa, no response, balance is okay. So yes, the 100 milligram of levodopa, probably you're taking 3 times a day. There may be much less or no response in patients with akinetic rigid state, or patients with non-tremor dominant Parkinson's disease. So probably if the dose of levodopa is increased, if your physician increases the dose of levodopa, you might notice the increase, some increase in response. Patients, I think we had this discussion last time as well. Patients who have tremor dominant Parkinson's disease, they have much prominent or robust response to levodopa as to patients who don't have a tremor. The patients who have non-tremor dominant Parkinson's disease, they may not have as a prominent response to levodopa. So this may be a situation where you have non-tremor dominant Parkinson's disease, and a low dose levodopa is not helping. Probably increasing the dose of levodopa may be helpful. I think you should discuss with your neurologist. So please tell us where are you joining us from, and also forward link to your friends and colleagues so that they might benefit from this. Let's go back to a question we had initially, involvement of face in Parkinson's disease. So as I said, facial masking, we covered a little bit about facial masking. There could be tremor prominent on the face. One of the most common tremor which you can see on face is a jaw tremor. Patients have a jaw tremor. Their jaw shakes, and some patients report that they feel they hear a noise of their jaw clicking. Other than jaw, patients could have a involvement of involvement of chin or lip, a low frequency, tremor of lip or lips or chin could be seen in Parkinson's disease. Jaw tremor could occur in patients with essential tremor also, so one need to be careful. They have to look at other symptoms of Parkinson's disease before attributing jaw tremor to Parkinson's disease. So in Parkinson's disease, beside facial masking, patients could have a jaw tremor, lip tremor, or the tremor of chin. Chin tremor can also be a familial condition, which is a separate discussion. So Parkinson's disease does affect face, and sometime if the facial involvement is very prominent, then one could tell just by looking at face, or a experienced physician can tell from the face that the diagnosis is quite obvious. So it makes things more prominent, or it makes physicians more comfortable to see those signs. Sometimes due to decreased eye blinking, patients can get inflammation of the eyelid, such as such as blepharitis, so that could be also a facial problem. Other than this, dry skin around the eyebrows, in the scalp, or in the ears with seborrheic dermatitis is also a sign of Parkinson's disease, which is not uncommon. And there is another question: are there any other movements on face during PD? During Parkinson's disease, there could some other problems involving face, although they are not limited to Parkinson's disease only, such as patients who have blepharospasm. So blepharospasm is when the muscles which circle the eyes, they make upper and lower eyelids, and also the corrugator muscle between the two eyebrows on each side and procarius, they may go into spasm, and these patients have trouble opening their eyes. Sometimes they may have to open their eyes manually by using their fingers, or other patients may notice increased eye blinking or increased eye closure. This may become more prominent when they are exposed to wind or they are exposed to glare. So that blepharospasm has been associated with idiopathic Parkinson's disease as well as in patients with atypical Parkinsonism. Other problem with the face could be drooling. So you can see drooling, which is pulling of saliva in mouth, and it can drip. It can cause poor oral health, and it can also cause a breakdown of lips. So these are also manifestations of Parkinson's disease on the face. So we have another question from the same person whose mother is unfortunately affected with Parkinson's disease. He is saying why she faces stillness after taking the medication. Initially, it remains for 15 minutes after taking medicine, and then stiffness starts after 2 hours. We don't understand why it happens. So, where neurologists suggest to take medication after 4 hours. Yes. So what your mom is experiencing is when she takes levodopa, it takes about 15-20 minutes to kick in. During that time, there is no effect of levodopa on her body, so she feels a stillness. By stillness, you mean she feels slow, she is frozen, she's not able to move, or she is much less mobile. So that period, although she has taken medication, so that is a time period after taking levocarb and the absorption of levocarb or reaching brain. So that time is usual to take 15 to 20 minutes after taking levodopa, that patients don't feel the effect. And during that time, she is slow. And then you said that then she feels stiffness, which start after 2 hours. So after 2 hours, so between those 15 minutes when the effect of medication starts and up to 2 hours. So for about hour and 45 minutes, the levodopa helps her. So during that time, she probably is less stiff or somewhat mobile. And after 2 hours, the levodopa starts wearing off. The effect of levodopa starts going away, and therefore the stiffness comes back. So that is very usual in patients with advanced Parkinson's disease, that they experience these motor fluctuations of on and off. So first, she has no on for 15 minutes, then she feels on when the stiffness is decreased, and then she starts wearing off. So that is common, and we try not to decrease the gap between levocarb because it becomes inconvenient for patients. So to address these problems, there are some other strategies which can help to have the effect of levodopa stay for longer period, such as other medications could be added, which could help depending upon the symptoms of patients. If they don't have any psychosis or cognitive issues, then these patients may benefit from adding of COMT inhibitors such as entacapone, so that may help to prolong the effect of levodopa. Other medications which may help in some cases could be salicyline, which is a monoamine oxidase B inhibitor. So monoamine B oxidase inhibitor. The other Other drug of this class is resegeline, which is once a day, so that can also help to prolong the effect of levodopa in the body. And other than this, patients could sometime take dopamine agonists, which may help to provide them benefit because of their longer half-life. In the periods when the effect of levodopa decreases, these patients may have some benefit from dopamine agonists. So these strategies may help to prolong the effect, and sometimes what happens, if the dose of levodopa is too low, then the effect will be for lesser duration also. So your mom is taking half a pill every 4 hours, so probably increasing the dose of levocarb might be helpful. If she moves to full tablet, that could be beneficial. And other than this, if her own neurologist could consider adding one of those medications, such as entacapone or selegiline or resegeline, that might be helpful as well. Thank you very much for joining us from different parts of the world, and please join us next Saturday, 3 p.m. We'll be doing the session again. The sessions are for educational purposes only, to share experiences of different patients with each other and what we see, what our patients tell us, to convey to you and share with you. Please forward this link. You can join us on YouTube and Facebook Live and ask questions. The address of the website is www.pdprogram.org, and World Parkinson's Program is a charitable organization, is a Canadian-based organization which aims to reach every Parkinson's patient. The aim of the scope and aim and mission of World Parkinson's Program is much different than all other regional and local Parkinson's organizations. Most of the organizations are working on research, which is a very great initiative, but World Parkinson's Program is much different. It's trying to address daily needs of those patients who are living and struggling with Parkinson's disease today, because the results of research may not reach those patients who are living in underdeveloped countries, or the research findings may come after some time, who knows, after 1 year, 2 year, 5 year, or 10 years. Although we have to support research, however, there is a large number of patients who are living in different parts of the world. They don't have access to medications, walking aids, educational literature in their own languages. So 80% of population in Asian and African countries lives in rural areas. They may not be able to read their own language even. So therefore, World Parkinson's Program is taking this path of supporting those patients, trying to provide them medications, and also trying to provide them educational literature in their local languages and walking aids. So please support World Parkinson's Program by visiting their website, www.pdprogram.org. We'll see you next Saturday. Thank you very much.